Good morning friends, I'm Dr. Hardik Seth. My topic today is all inside ACL. I'm just going through the main steps and differences with the normal transporter technique of ACL. So first is only semi-tendinous graft is harvested in for the all inside ACL, and graft preparation is little different. Here we prepare the graft with graft link preparation. So on both the sides, tightrope buttons are there and loop buttons. So semi-T was 4-folded and graft link preparation done with end-to-end suture once, and then one 4 loop on one side of the tightrope and other on one is on other side of the tightrope button. And then marking is done as usual, just from the button for the femoral flipping, from the button to the tunnel total femoral condyle length, and for the passage for the graft length in the femur, we mark it on the femur side only. And usually we can reduce the graft length to 55 mm also. So 15 mm for femur, 15 mm for tibia, and for 20 mm for intra-articular, or 20 and 20. 60 to 70 mm is enough. Another advantage is, another difference is we are using flip cutter here for the tibia and femur both with all inside zig. So this is a flip cutter that is closed, that is 4 mm in diameter, that is drilled with zig into the tibia, and after it is inside under arthroscopy vision we flip it. Now we have that all-in-one preparation, all-in-one flip cutter available. So we only with one flip cutter we can use 7, 8, 9, 10 up to 10.5, 11 mm diameter drilling. So with opening of this, the flip cutter flips, and then you can drill it back 20 or 25 mm as per required. This is femoral zig for all inside, but even if we are not using all inside femoral zig, that is okay. We can do it as our transporter technique for femoral side fixation. After drilling, on both the sides socket preparation is done, and here the graft is passed through the medial portal. So on both the sides, first femoral we pass a loop, we make a loop from medial hole, medial portal, and again another portal loop is also made for the tibial socket. Both the loops are fixed, and then graft is passed first on the femoral side, fixed with the endo button, and first it is fixed on femoral side, but still we can keep 5 mm gap so that we can tighten it later on if needed. Then the graft is passed through the tibial side. And it is fixed in extension, just 5-degree flexion, and then you can retighten it for the femoral side with flexion, and on tibial side in extension. 5 mm cortex has to be kept intact on both the sides. This is post-op X-ray, loop button, tightrope button on femoral side, and no loop button with suture disc on tibial side. For post-op protocol in all inside ACL, we are protecting the bone, preserving the bone cortex on both the sides, so we can mobilize the patients earlier. Rehab is faster. From the second day, we can ask patient to put full weight bearing, and pain is much less as compared to the routine transporter technique. That is the main advantage of it. And even in multiple ligament surgeries, if we are using all inside technique, then it is much more useful, as we are using only semi-T graft, so the graft is also available, and bone is also preserved. So in revision cases if required, this is good. Even with in studies, this is a systematic review that is comparing transporter with all inside techniques, and it shows there are less, as I have said, less pain, faster rehabilitation. Other advantage is dilatation of the tunnel is less with this technique, and even with suspensory fixation, normally we are doing windshield wiper effect and bungee effects are more, but with this all inside technique we are using just a socket, and that also we fill with the graft. So chances of bungee effect and windshield wiper effect is also less with this. And bone integration, bone to graft integration is much faster as the socket is closed, so the flow of the synovial fluid is very less. Backflow of synovial fluid is very less. So bone to graft integration becomes faster. So rehab means later on longer rehab is also becoming easier for these patients. Thank you.